Thank you very much for the invitation to talk about the results of the SPARE trial, which have been presented here at the ESMO meeting in Munich 2018. So up to now, patients who start on treatment with abiraterone acetate for castration-resistant prostate cancer are mandatory to continue androgen deprivation therapy, either by LHRH analogues or LHRH antagonists. However, if you look at the mechanism of action of abiraterone, you could think of sparing the LHRH therapy, since abiraterone is even more effective in lowering serum PSA levels. So the idea of the trial was to see or to look whether or not you could spare the LHRH therapy when you start on the treatment with abiraterone acetate. So the design of the study is a randomized phase 2 trial. However, we did not power the trial for a direct comparison of the two treatment arms. So this is just an exploratory phase 2 trial. So what we did was that we entered patients with progressive castration-resistant and chemotherapy-naive prostate cancer on this trial and randomized the patients in two arms. The first arm, Arm A, was continuation of LHRH therapy in combination with abiraterone acetate and prednisone. And Arm B, the second and experimental arm, was starting abiraterone acetate and prednisone and stopping the LHRH therapy at the beginning. The primary endpoint of this trial was radiographic progression-free survival, similar to the endpoints of the Cougar 302 trials, which was a registration trial for abiraterone acetate in this setting of castration-resistant prostate cancer. Secondary endpoints included time to PSA progression, PSA response, objective response, safety, and changes in the hormones of the pituitary gonadal axis. So the main results of this trial are that we can see that in the experimental arm, if you stop LHRH therapy, you still see a high degree of PSA response with a long time to PSA progression. And this is similar or comparable to the results of the Cougar 302 trial, and quite similar and statistically not significant different to the comparative arm with continuation of the LHRH therapy. So regarding the primary endpoint, even though the trial was not powered to see difference between the two arms, we did not recognize a difference in radiographic progression-free survival in this endpoint. So in conclusion, what we see is that even if you stop LHRH therapy, we do not see, or we still see, that abiraterone acetate is still very active with regard to PSA decrease, progression-free survival, PSA progression-free survival, and all the other endpoints. So that we think that in the future, patients might stop LHRH therapy when they start abiraterone acetate. The results of the safety analysis are still pending, but what we see is that the treatment duration in the control arm with the continuation of LHRH therapy is a little bit shorter compared to the experimental arm. So this is at the moment a suggestion, but probably we see lower side effects if you stop LHRH therapy, and this could be a great advantage for the patients. So the next steps are to finalize the results of this trial, and then probably go on to a phase 3 trial comparing both arms, continuation of LHRH therapy compared to the cessation or stopping of LHRH therapy, to get a high evidence that abiraterone acetate monotherapy is as effective as the combination therapy.